Hi, my name is Samo, and I'm a third-year FPMRS Fellow at Northwestern University in Chicago, Illinois. Today, I'm proud to present our study titled Cost-Effectiveness of Prophylactic Retropubic Sling at the Time of Vaginal Prolapse Surgery. I would like to thank ICS and the entire planning committee for allowing us to present our work. I have nothing to disclose. In the OPUS trial, placement of prophylactic midurethral slings during vaginal prolapse surgery for continent women showed a 36% risk reduction of de novo urinary incontinence. However, concomitant sling placement was also found to be associated with bladder perforation, incomplete bladder emptying, and urinary tract infection. Based on this information, pelvic reconstructive surgeons' approaches to prophylactic sling at the time of prolapse repair vary, and there has not been a standardized and uniform approach to the role of prophylactic sling at the time of vaginal prolapse repair. As a result, the objective of this study was to compare the cost effectiveness of three midurethral slings utilization strategies in preventing de novo stress urinary incontinence 1 year following vaginal prolapse repair. We created a decision analysis model to compare three approaches. First, staged vaginal prolapse repair alone without sling. Second, universal sling, vaginal prolapse repair with concomitant sling. And three, pre-op cost stress test, vaginal prolapse repair with selective sling based on pre-op cost stress test. We modeled a representative population of women with symptomatic pelvic organ prolapse of at least stage 2 and without pre-existing urinary symptoms. In our model, vaginal prolapse repair included colpochliasis, apical suspension, and/or anterior-posterior repair. We assume all repairs were uncomplicated and successful. In this model, no urodynamics was used, and all procedures in this model were outpatient surgeries, and we studied a 1 year time frame to reflect the available follow-up data from the OPUS trial. We then created subsequent treatment pathways if de novo SUI was to occur after vaginal prolapse repair. We used a 2017 systematic review by Vanderplug et al. To obtain high-quality literature for our point estimates of de novo SUI rates, as well as PubMed to identify new articles published after this review's January 2017 cutoff date, searching for new publications relevant to our study using similar search terms. In this study, we chose to model a retropubic midurethral sling as the surgical treatment of de novo SUI. To determine the risk of adverse outcomes from midurethral slings, we evaluated three studies and determined four possible adverse outcomes after sling. First, recurrent SUI. Second, 40 dysfunction requires sling lysis. Third, mesh exposure requiring excision. And fourth, de novo overactive bladder requiring anticholinergic medications. In our model, we assume no more than one sling may be implanted per patient. Here is the table showing our base case assumptions calculated from existing literature. Final probabilities were calculated using a weighted mean of included studies if multiple studies reported the same outcome. Costs were gathered from the Medicare reimbursement data from the 2020 CMS Physicians Fee Schedule or determined from the literature and converted to the 2020 US dollars with Consumer Price Index. For measurement of effectiveness, it was measured by Quality Adjusted Life Years, or QALYs, using previously published articles. Health utility value for no SUI and no OAB was 0.93, while health utility value for SUI and UUI on medication were 0.71 and 0.82 respectively. If the outcome included both SUI and UUI, we used the lowest health utility value. The primary outcome model was ICER, which is the ratio of the difference in cost to the difference in QALYs between scenarios. An ICER threshold of less than $50,000 per QALY was considered cost-effective in this study. Then we test the robustness of our model by performing multiple one-way sensitivity analyses. Finally, we calculated numbers needed to treat using the base case assumptions to determine case number needed to prevent one adverse event. When compared to stage vaginal prolapse repair, pre-op CST and universal sling are both cost-effective, with pre-op CST being less costly per QALY than universal sling by over $5,000 per QALY. When considering cost alone, the variable with the largest effect in this model is the percentage of women experiencing de novo SUI who chose to undergo midurethral sling surgery as their treatment. With an increasing share of women with de novo SUI electing to undergo sling, a universal sling would then replace pre-op CST to be the more cost-saving strategy at 61.8%. Multiple one-way sensitivity analyses showed no other meaningful thresholds that would alter the conclusion of this model, including varying rates of sling lysis, mesh exposure required excision, treatment of OAB, false negative CST, or cost of CST. When considering either preventing sling complication by doing more stage approach or reducing numbers of retreatment with sling by adapting pre-op CST testing approach, we evaluated the numbers needed to treat in order to prevent adverse outcomes when the surgeon adopted either stage or pre-op CST approach. As shown here, a surgeon would need to perform 22 pre-op CST cases to prevent one stage patient from returning to the operating room for midurethral sling surgery. Conversely, with the goal of reducing sling complication, a surgeon will need to perform 39 stage cases to prevent one patient from needing OAV medication after sling, 61 stage cases to prevent one sling license for voiding dysfunction, and 156 stage cases to prevent one mesh excision for exposure. Our cost-effective analysis found that both pre-op CST and universal sling were cost-effective during a one-year post-op period when compared to stage approach. Of the two, pre-op CST approach costs less than universal sling approach per quality. However, universal sling becomes more cost-effective when more women chose to undergo sling to address their de novo SUI. Women should be carefully counseled regarding to the possibility of de novo SUI after vaginal prolapse repair, as well as the benefits and risks of concomitant versus stage sling surgery. However, the decision to adopt either approach should be made based on the woman's treatment goals and priorities. The findings from our model should be incorporated into these dialogues with the patients. Here are our references, and thank you again for the opportunity to present our work, and I would be happy to answer any question.